Good evening, delegates and all the participants. This is Sahiti on behalf of Shield Connect, welcoming you all for the today's topic, Newer Insights in Women's Health, organized by EMOX Family Welfare and MTP Committee, along with Food and Drug Medical Legal Surgical Equipment Committee of FOXY. Let me introduce the coordinators of the today's program. Dr. Asha Jain, ma'am was the director of SMSA Hospital and medical director of NGO Cancer Prevention and Relief Society. I welcome you, ma'am.
Thank you.
Dr. Alpana Kansal, ma'am was practicing at Raj Maternity and Surgical Center, Ghaziabad, and also ma'am was the member of MTP Committee of FOXY. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. I would like to introduce our conveners today, Dr. Ritu Khanna ma'am and Dr. Komal Chauhan ma'am. So Dr. Komal Chauhan, we all know her. She is an MD, DNB, MNA, MS and all. And she is the chairperson. She was the chairperson FOXY Medical Disorders of Pregnancy Committee, Zonal Coordinator for FOXY President 22 to 23, Chairperson AMOGS Family Welfare and MTP Committee, Member Managing Council MOGS, Joint Secretary ISOPAP, Scientific Secretary AFG, National Expert for FOXY UNICEF Lakshya Project, National Trainer for FOXY Dhira and RAC Project, Convener FOXY Guinness World Record 2021, Break Free from Anemia. She has many prizes and she is standing for Vice President West Zone right now. Welcome, Dr. Komal.
Thank you so much.
Dr. Ritu. So I also welcome Dr. Ritu. It's a great pleasure to welcome our ever smiling committee chair from FOXY Food and Drug and Medical Surgical Equipment Committee. She is the director of Khanna Medical Center and Fertility Clinic, Varanasi.
Thank you.
Executive member, Scientific Secretary of IMS Varanasi chapter.
Thank you so much, Dr. Asha.
So,
thank you so much.
I invite both of you conveners to please welcome all our guests and we can proceed for the lamp lighting.
Yeah, we can do the lamp lighting.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
Yeah, thank you so much. And I was just connecting with Dr. Pai and he's about to join in some time. He's sent a message that start the program. So regards to Dr. Rishikesh Pai, our president FOXY, he is doing really wonders, be it Yatra or be it the scientific work or the conference. Every weekend we are having a lot of academic activities. He is doing a lot of international activities also and making us proud on the international as well as national front. So when Sir comes, we can formally introduce him. But we have our Secretary General, Dr. Madhuri Patel here. She is the first lady female Secretary General. She is also on the committee of member of PIGO, that is on preterm birth, associate editor of Journal of Obstetrics and Gynecology, that is Jogi Journal. She is a clinical associate, Nauroji Badia Hospital, Parel, Mumbai, and honorary consultant at Police Hospital, Mumbai, visiting consultant at St. Elizabeth Hospital, Mumbai, and she has delivered a lot of presentations. And she is yes, thank you, madam. Madam, we are waiting to hear from you. Thank you.
Yes. Thank you, Komal, for your kind and generous words. Respected our President FOXY, Dr. Rishikesh Pai, most dynamic and visionary, which Komal has already elaborated. But let me say that in the end of June, we had the FOXY RCOG day over there, and we exchanged our views, the treatment from India and treatment from London, UK end. And it was a very good initiative. So many initiatives have done, and he's the most dynamic and visionary, I must say. Then we have Dr. Yashodhara Pradeep, our Vice President, Foxy. Very well, meticulous and dedicated person. Then, of course, Dr. Rajendra Singh Pardesi, I don't require to say anything. He is a president amongst and very great friend of mine. We have worked together when he was Vice President Foxy, and we have been associated with each other since last 3 to 4 decades. Then, of course, we have our Dr. Sujata Dalvi from Mumbai, who is Secretary AMOX. Then our program convener, Dr. Komal, Dr. Ritu Khanna, and they are the committee chairs from AMOX as well as the Foxy, and they have done the wonder. Then we also have program coordinator, Dr. Apana Kansal, Dr. Asha Jain. Then we have Ajay Mane, our Vice President-elect Foxy, and Dr. Mala Srivastav, Dr. Kiran Sinha, Dr. Sushma Gupta, Dr. Banita Sae, Dr. Vidya Thobi. Again, we had lots of opportunity to work with her. Dr. Dana Lakshmi, Dr. Varsha, Dr. Udaya, Dr. GB Madhavi, Dr. Uma, Dr. Swati, and all my dear friends. Very good evening to all of you. At the outset, I would like to thank Foxy, Dr. Rishikesh Pai and team, AMOX, Dr. Pardesi and team for giving me this opportunity. As in Secretary General of Foxy, I always like to talk about Foxy, that Foxy is the most vibrant, prestigious, and one of the largest OBGY professional organization in the world with 266 member bodies and 40,000 plus committed members to women's health. And we have 28 committees in Foxy, and you have seen all the committees are doing excellent work. Similarly, AMOX, we consider as a part of Foxy. Our members are same, our missions are same. The main mission is reduction in maternal mortality rate. And let me tell you, we have achieved that to 97 to digital per 100,000 live birth, and we are marching towards our sustainable development goal of MMR less than 70 per 100,000 live birth by 2030. So let us, we all work together for the similar mission and for the women's health. So on this Population Day, we know that the population of the world is increasing by every minute. The prevalence of population-related issues are increasing as the population is growing. From poverty to economy to maternal health, and the global generation generates a plethora of issues that require attention, efforts, and changes. World Population Day serves as a reminder to continue working and striving to improve conditions for all people living on the planet. The United Nations established this special day as 11th January on 1989 because they realized the population of the world in 1987 was 5 billion. And today we are almost 8 billion. And can you imagine that India, we are 1.43 billion. We have already surpassed China in the population. So now this 11th July, every year is, observe that we have to control the population and the related problems. At the same time, we have to improve the maternal health. And today's all three committees are doing excellent work of making aware people and sensitizing and updating the knowledge in contraception, vaccination. This will not only help our members but also our women. So we have today very galaxy of eminent speakers, chairperson, experts, and of course moderators and panelists who are going to enlighten us on important topics, which will help us in day-to-day practice to benefit our mothers as well as our nation in maternal health as well as the population. So I congratulate the team and I wish them best luck. At the end, I would like to quote Albert Einstein. Education is not the learning of facts. education is not the learning of facts, but it is training of mind to think. So even if we are knowledgeable, but we have to think every time. And so dear friend, let us use this thinking of our mind to give the best to our women. So thank you once again for giving me this opportunity.
Thank you so much, Madhuri Madam, for your lovely words. And definitely today is the World Population Day, and we all are having a big responsibility on our shoulders because India is the largest populated country. And really in this year's theme, which is unleashing the power of gender equality, uplifting the voice of women and girls to unlock our world's infinite possibilities. And I think India is progressing towards us. We all are making our collective efforts, and these are going to lead us definitely to have a good women's health. That is the motto of FOXY as well as AMOX. And I hand over to Ritu for the further proceedings.
Thank you, Komal. Thank you, Madhuri Mad, for your blessings. And it's Yashodhara Madam has joined. I think Madam has not joined. So we just move on. Asha Madam is there. So it's an honor for me to invite a stalwart, a very loving person and a renowned infertility and endoscopic surgeon. And that's Dr. Asha Bakshi Madam, who is a lead consultant at Asha Bakshi Fertility Center in association with Motherhood Hospital Indore. And she is the vice president of FOXY. And of course, lots and numerous awards and accolades to her credit, and I would not take much time. We need to would like to listen to her. So over to you, Asha Madam, for your blessings.
Thank you, Ritu.
Before Asha start, Asha, I forgot to take your name, so sorry for the same.
No, man, no problem. Thank you, Ritu. And I'm so fortunate to be the part of the team which is being led by Dr. Rishikesh Pai, a great visionary who always thinks out of the box, and you really have to really match with his ideas. And he's doing tremendous job, and lots of groundbreaking things that he's doing, which we had never heard of. And one, as Madam said, that this was the FOXY India Day on in London, and the dinner at House of Commons, which is absolutely unthinkable of. And it was an experience. I think that because I have worked in England for such a long time, and these were the things I had just seen, and now there being a part of that particular system was really good, and that it was an unforgettable event. And Madhuri Madam, as usual, she's so particular. And I think she knows how to discipline all of us, and very knowledgeable person. So I'm very happy to be part of this particular team. And congratulations to Dr. Ritu and Dr. Komal for keeping this webinar, which is a theme-based webinar on the Population Day. And my best wishes to Komal for her future endeavor. And so nice to be part of AMOX, which is being led by Dr. Rajen Singh Pardesi and Dr. Sujata Dalvi. They both, I really like them very much. And AMOX, we all know, is doing very good work. And always you keep hearing lots of activities of AMOX, and today's activity is one of them. And the conveners today, Dr. Alpana and Dr. Asha, you are doing great job. And so nice, the topics selected are really good. One is documentation in tubal ligation by Dr. Ajay Mane. Ajay is, I think, perfect person for such topic. And I think we all have to save ourselves, and documentation is really going to save us. And today, there's so many things, technologies there, you can do recording, and digital technologies there. So this is all going to help, and we should be adaptable. We should adopt, and that is all to protect ourselves so that obs-gynae practice becomes easier. Otherwise, new generation is not wanting to go in for obs and gynae. So we all have to keep safe and show to the new generation that obs-gynae is very good if practiced properly with proper record keeping and keeping ourselves safe also. And postpartum contraception, again, is going to be the next topic by Komal, and that also is the demand of time, because that is the time woman is most susceptible to hear about contraception. And again, the vaccination, I think Ritu loves vaccination, and even I love them, because prevention is always good. And people just think that vaccination means children, and I think vaccination means whole population. And if you vaccinate the woman and she's healthy, she will definitely encourage others also to others in her family members. And geriatric vaccination, which is really a very neglected topic in our country. We don't bother about pneumococcal vaccination and all those things which routinely happen in the Western countries. So I think if we increase the awareness, then our whole population and more, we are going to see more and more elderly population. So very important to have these preventive practices. So I wish you all the very best, and I'm sure this webinar is going to be very, very good. Thank you very much for inviting me.
Thank you, madam, for your love and blessings. Thank you so much. Over to Komal to invite Dr. Rajendra Singh Pardesi, sir.
Yes, thank you. Thank you, Asha, madam, for your lovely words and your wishes. Now I take pleasure to invite our AMOX president, our very own Dr. Rajendra Singh Pardesi. And
It's
Dr.
okay,
Pardesi,
it's okay, Komal. We can skip that.
yeah, and
Ah,
I just
good
want to say
afternoon.
one word, that sir is the most approachable, he's very dynamic, and he has a lot of insights into women's health as well as, health for his own fellow doctors. So that is most important, and that is a true quality of a leader. So over to you, Dr. Pardesi.
Good afternoon, everybody. Respected Dr. Rishikesh Pai, Dr. Madhuri Patel, Dr. Yashodhara Pradeep, Dr. Asha Bakshi, Dr. Komal Chavan, Dr. Ritu Khanna, Dr. Ajay Mane, Dr. Vidya Thubbi, Dr. Sujata Dalvi, Dr. Varsha Lad. I am feeling proud and honored to be a part of this program. Not as AMOX president also, but this is a program of Food and Drugs Committee, and which is close to my heart. As Dr. Ritu Khanna is chairperson of Food and Drugs Committee, but I was also chairperson of Food Committee, and even Vidya Thubbi is also there now. She is president of Kasuga. So Dr. Ritu Khanna from Food and Drugs Committee, you will be ahead, don't worry, and we are all with you.
Thank you, sir.
So I wish to congratulate Dr. Komal Chavan and Dr. Ritu Khanna for organizing such an academic and practical webinar on the eve of World Population Day. As Dr. Madhuri told, documentation is very important, which Ajay Mane is able faculty will be taking, and Dr. Komal Chavan is addressing, and even Dr. Ritu Khanna and Dr. Vidya Thubbi, and these are the giants of Food and Drugs Committee. They will be taking the panel discussions on vaccines and all that. And with the galaxy of speakers, faculty chairperson, I think this will be a great event. Dr. Mala Srivastav is there. She's contesting for chairperson of vaginal surgery. We wish every success to Dr. Mala. Just to say a few words about Dr. Komal Chavan, she is very active. She was active in FOXI. She is active in AMOX also. She is hardcore academician. We wish every success to Dr. Komal Chavan for our vice presidential election of FOXI. Wishing every success to this webinar. I don't want to be between you and scientific content. Thank you. Thank you so much for inviting me. Thank you.
Thank you. Thank you so much, sir. Thank you. Your words mean a lot to me. Thanks a lot. Over to you, Ritu.
Yeah, thank you, Komal. And thank you, sir, for your blessings. And now it is an honor for me to invite a great academician who's so vibrant, so dedicated. Madam, the day I saw you, the dedication, the passion, I can never forget. And we can just see AMOX going to so much of heights. And I feel Sujata Madam is a person who has very, very clear vision and is so humble at heart. So, Madam, we await your person.
Ritu, you can skip all that. Yeah, I'll start off. So at an outset, I would like to thank the organizers for giving me an opportunity to speak on behalf of AMOX as a secretary. I would like to express my gratitude to FOXI President, Dr. Rishikesh Pai, and his vision. And he's so hardworking and he makes everybody work very hard. Also, AMOX President, Dr. Rajendra Singh Pardesi, who's always very supportive. So far as scientific sessions are concerned, I would like to express the words of wisdom which were given by Dr. Madhuri Patel, FOXI Secretary also. And also I would like to express gratitude to AMOX Family Welfare Committee and MTP Committee Chairperson, Dr. Komal Chavan, and of course, Dr. Ritu Khanna as a FOXI Food and Drugs Committee and Surgical Equipment Committee for arranging this webinar on a World Population Day, which is very important. And the topics that are being covered are so relevant that I'm sure that those who have logged in will learn a lot and they'll be able to implement the same in their practice so far as an upliftment of a maternal healthcare is concerned. And I would like to wish best wishes for today's webinar and also best wishes to Komal for a future endeavor in Foxy. Thank you so much, Ritu.
Thank you so much, ma'am, for your pearls of blessings. And before we start, we need to thank, and a special thanks actually to Dr. Lakshmi Madam, Shirikande Madam, and Dr. Parag and Dr. Ashok Kumar for crediting this CME with 3 ICOG points. With this, I hand over to our dynamic, the program coordinators, Dr. Alpna and Dr. Asha.
Good evening, everyone. Good evening, everyone. After taking blessings of Almighty and our seniors, now we start today's first session, which is on documentation of tubal ligation. For this, I take opportunity to welcome the chairpersons, Dr. Mala Srivastava. Ma'am is head of Gynae Oncology Unit, Sir Gangaram Hospital, New Delhi. And her areas of interest are Gynae Oncology, Gynae Endoscopic Surgery, and Gynae Robotic Surgeries. She has many awards to her credit. And to name a few, Foxy Achiever Award 2023, APJ Abdul Kalam Excellence Award, DGF, and lots of prestigious posts have been taken by ma'am in AOGT, NARCHI, and GRIPMA. Welcome you, ma'am. Now, our second chairperson is Dr. Kiran Sinha, ma'am. She is Senior OBGY at Kanpur and has retired from PHMS as Joint Director, Kanpur Mandal, Kanpur after 35 years of services. And presently, ma'am is Secretary, Kanpur OBGY Society and Secretary, ISOPA. Welcome you, ma'am. Our third chairperson is Dr. Vidhu Modgir, and she is Senior Fertility Specialist at Suman Hospital, Ludhiana, and is past President, Ludhiana OBGY Society, and she is actively working with many organizations in Punjab. Welcome you, ma'am. Now I request Dr. Mala Srivastava, ma'am, to kindly introduce our speaker, Dr. Ajay Mane, sir.
Thanks, Dr. Alpana, for your introduction, kind introduction. It's my pleasure and privilege to introduce the star speaker of the evening, Dr. Ajay Mane. Sir is the Vice President, Foxy.
माला मैडम, ये तो मेरा सम्मान है कि आपने मेरा नाम ले लिया है. अभी इंट्रोडक्शन हम लोग skip कर सकते हैं. You are very senior to me in all aspects.
About you. So we are, you are the second Joint Secretary of AMOGS, and everybody wants to know that you are the medical legal consultant since last 18 years, and you have been guiding each and every Foxian free of cost.
Yes, ma'am. 100% true.
Yes, that's true. And every Foxian should know where to go in case of trouble.
Yeah, thank you.
And you have been chairperson, official AMOGS website, Sexual Medicine Committee, and Adolescent Health Education Committee, and you have been past president of Aurangabad OB-GYN Society. We are waiting to hear from you about your scientific deliberation. Over to you, sir, for your scientific deliberation and how to document our points for tubal ligation.
Yeah, thank you, Mala madam, for kind words. And hearing from your mouth is a very great pleasure for me. From such a stalwart, I'll start my presentation. So, is it seen? Hello.
Your PPT is not visible, sir.
Okay. Just give me 1 minute. Screen that share.
Screen.
Now is it seen?
Yes, we can see.
Yes. Thank you, madam. Thank you very much. Yeah. Now is it seen?
Yes, sir. Yes, sir. Yeah.
Okay. Thank you very much. So to start with, I must convey my gratitude to Rishikesh sir, Madhuri madam, Yeshudhara Pradeep madam, Asha madam, and Rituji, and my own mentor, Dr. Rajan Singh Pardesi sir, Sudha Dalvi madam, who is Secretary AMOGS, then my dear sister Komal, then Alpana madam, Asha Jain madam, and yourself, Mala Srivastava madam. Then my chairpersons, Kiran Sinha ji, Vidhu ma'am, and Vidya Thubi madam, who is a Kasoga president. So thank you very much for giving me the chance to be here amongst all you stalwart people. So my topic is documentation in sterilization. Basically today I got a call from Hyderabad And she was working in somewhere in the Uttar Pradesh and went back to Hyderabad, and now she has got one notice from police and the medical council that you have done such and such things, and now there is allegation against you. So she said, "Ki, sir, everything is there, and they have removed one page from my papers of the consent." So this is the importance of documents. If the consent paper is missed, so you cannot do anything. So keep a copy with you. So I asked her to go to the higher organization where she has referred the patient and get a paper from there. She got the paper from that institution where the paper is present. So she is saved. And kindly make a habit of putting a number on the right upper side, 1, 2, 3, 4, 5, 6, 7, 8, whatever it may be, and keep the paper. So if a single page is been mischievously torn or missed there, you can point out to the judiciary system that, see, after 6 there is only 8. Where is the number 7 paper? So it was very important. That the point where you can save yourself. So document is very important because it is the only proof what you have done and what you have explained. If you have not mentioned anything in the documents, then it is considered as you have not done. Though you have done, it is not considered as done. Okay. So list of documents: OPD case paper, second indoor case paper, registration in R3 register. I'll be showing you the samples every document. Written informed consent in India. We need only 3 informed and written consent. That is, one is PCP entity, second is MTP, third is organ donation. But patients are hostile nowadays. We cannot believe anybody. So we must have a written informed consent. That's all. Then OT register is very important, where we put all the details. I'll showing you the columns. Then certificate of sterilization, which will be given after a few days, and follow-up schedule. So that is the important papers. OPD case paper and indoor case paper. See, routine OPD case paper with identity proof. See, nowadays we don't know who is coming to us. So every hospital nowadays are having electronic system. As Asha madam said, we must adapt newer technologies. The newer technologies, you are taking photograph of the patient, putting the identity in your computer. It will be printed, and additional soft copies also saved. That is the ideal system. And you are asking for a valid ID proof, maybe Aadhaar card, maybe PAN card, maybe a voter card, maybe a ration card is not in valid ID because the photo is not there. Okay, where the photo is there is a valid identity proof you should take. And why identity proof? The person is identified, and second, the date of birth is identified, because less than 18 years is a POXO case. So you need to inform the police. Many times it happens that we put age 18 and she is primary of 32 weeks. Means what? When she conceived, she was minor. She was not 18 years. Then again, you need to inform the police under POXO. That's why we need identity. Okay. Second is indoor paper for operative procedure with the consent. OT procedure notes. OT procedure notes must be written by the surgeon only. No nursing assistant, no surgeon assistant should write that. Okay. Then follow-up schedule must be given on that, and discharge card. Here, if the procedure is done under anesthesia, the anesthetist consent is a separate consent, and anesthetist notes are separate. That should be put by the anesthesiologist only. Mind it, the timing of the surgeon and the timing of the anesthesiologist must be same. Or if something goes wrong, surgeon is putting that at 5 p.m. patient was all right, and anesthetist says 5 p.m. patient was pulseless. This should not happen. I have seen the cases. Okay. And the general guideline I have. What is the eligible criteria for vasectomy? The client, that is, the client should be at least 22 years, upper limit is 60 years. Client should be ever married. Unmarried persons are not liable for this operation. Then the couple should have at least one child whose age is above 1 year. That is same for female also. Client or their spouses must not have undergone sterilization. If the TL is done for the woman, then you should not go for the vasectomy for the same husband. Client must be in the sound state of mind. If he is not under the sound state, then we need a mentally ill client must be certified by the psychiatrist, and statement must be given by the. Okay. What are eligible criteria for the providers who is doing the operations? Any trained or empaneled MBBS. MBBS is the basic degree which we need. Nowadays, Ayush doctors are there. We are not going into the quarrel of that Ayush or MBBS, but we need at least MBBS doctors who has gone training or who is a super specialized, like the DNB degree, diploma, or MCH, anything, gynecologist or a surgery MCH, right? And that the state should maintain a district-wise list of surgeons. So, okay. Then what is the procedure? The provider must ensure that the client has made an informed and voluntary decision, because it should not be by forceful. Chal tere ko kar le operation nahi to hum tere ko uda denge. Likewise, it should not be forceful, both for TL and for vasectomy also. They must be coming on their own. Ki chalo bhai kar lijiyegi. Okay. Client must be encouraged to ask questions to clarify their doubt, because this is a surgical and this is a permanent method. Okay. Failure bhi ho sakta hai. Isme aapka kuch complication bhi ho sakta hai. That everything should be asked by the patient, or you should tell the complications. यानी आप टेबल पे मर सकते हो ऐसा नहीं बोलना है. Remote possibilities मत बोलिए उनको. अगर आप ऐसे बोलेंगे तो कोई भी पेशेंट तैयार नहीं होगा. Okay. But the nearby possibilities है, failure है उसमें, या complications है, या infection है, ये चीजें आपको बोलना जरूरी है. ठीक है. And one more thing. Consent of the spouse is not needed. In Maharashtra, it is not needed, but in Government of India's document, they said ki preferably it should be taken. Means it is not mandatory there, but it should be taken. But usually what we take the spouse signature. Maybe a vasectomy patient, wife signature is there, for tuberculomy, husband signature, if husband is available. As a witness, we are taking the signature, because after a few years, they may come and have quarrel with you कि अरे आपने जबरदस्ती कर लिया हमारा, मेरा तो कुछ consent था नहीं. TL also we don't need consent of husband. Okay, that's clear. But for safety, we take that. And important part of counseling, client must be told that the reversal is possible, but it is not 100% possible. May or may not be there. Eligibility criteria for female sterilization, again 22 minimum. The upper limit they have not given. Rather, it is a 49 years basically. But in Government of India's document, it is not clear. In Maharashtra government, they have given 49 years. Otherwise, also menopause is there, 45 to 50. And the couple should have at least one child, again more than 1 year. And the spouse or the counterpart must not have gone under sterilization. All the conditions are same. Okay. The general counseling must be done. All the things must be told about the reversal, failure, complications, everything. Then that I okay, we'll skip that. Okay. The consent of the partner is not required for sterilization. Both I told you. What about the HIV/AIDS positive patient? They must be given a chance. They should not be denied. Basically, denying a HIV positive patient is basically considered as a crime. Rather, we should give them services with a full precautions, or a separate your instruments, your HIV kits and everything. It should be. And after sterilization also, they should be advised to use condom or not to propagate the disease. Then documentation of the informed consent. It must be a informed written consent, because patient may say afterwards, why in sterilization, the informed written consent is a printed format in Maharashtra. I'll show you the proforma, and Government of India also has given the proforma, and the document of the consent itself is an indemnity for the patients, because if something goes wrong, failure of the operation or the complication during and after the operation or the death of the patient, it is indemnity. The insurance is already given. So the informed written consent itself is a indemnity form for the insurance. So it is very, very much important. Okay. Then if the patient is not in condition to have operation by the surgeon, then the surgeon should give a documentation about denial of the sterilization. And what are the conditions? So they may give the 4 categories. A is accept, there is no medical reason to deny. Then second is C, for caution. The procedure is normally conducted in a routine setting, but with the extra preparation and precautions, with a higher setup or some additional surgeons or additional anesthesia or additional facility. Then D is delay. The procedure is delayed until the condition is evaluated, and because some minor infection is there or just infection is there, so we can delay the procedure. Otherwise, the patient is fit till the infection is covered, so it is delay. And yes, is special. where some special conditions are needed. Many a times we have seen that in government setup, the TL is done under local anesthesia. 2% xylocaine, it has been given to skin and the peritoneum muscle, and then it is done in local. But it is better to have an anesthetist along with you, because he or she may take care of the pulse and everything, and you are coolly and calmly doing the tubectomy. So personally, I'm having a habit of having anesthesiologist for each and every for MR also. I invite anesthesiologist. Okay. Nowadays, I don't do that MR and MTP, but anesthesia is always better. So anesthesia or analgesia, the types of anesthesia given in local only, local or analgesia, whatever you have given must be written on the paper. If it is local by you, then you must write that local is given by myself. No anesthesia was there. Okay. And general, no intubation, general with intubation. Any other means local or the regional block, likewise it can be there. Time, drug name which is given, dosage, and route. Signature of the anesthetist in case of regional or general anesthesia, it must be there. So then and then only it is a valid. Okay. Then follow-up counseling. Follow-up counseling, I will show you the so this is a sorry, R3 register. There are 22 columns, amongst which 22nd is a remark column, and yearly number, monthly number, patient's name. So this is a progressive number, yearly and monthly. They are progressive numbers. So everything is to be entered in this register, so we can have a good data to be given to the government. So government updates only here. Then written, I will show the document. This is a OT register. What are the columns? Yeah, this is a yearly number, monthly number. Again, they are progressive number, date, patient's name, age, address, type of anesthesia given, local or general or without, operation performed, PNC-TL, interval TL, whatever, name of the anesthesiologist, name of the surgeon, assistant, and remark. It is not like that. The name of the anesthesiologist must be written on the certificate, must present in the OT. No, any valid or MCA recognized degree holder can give the anesthesia. Okay. And name of the surgeon, again, same thing. In Komal's hospital, I can go and operate there, but the Komal's hospital must be recognized for the tubectomy. It is a separate registration done by the civil surgeon. It is not that you have got your Bombay Nursing Home Act and you are liable for the tubectomy. No, you must have a separate application to the civil surgeon, and they give you the separate. Then and then only your failure cases or your complicated cases are insured. So you must have a separate registration with the civil surgeon. This is certificate of sterilization after completion. So it is given that the pro forma is there. I'll read out this one. For female sterilization, she has resumed her menstrual cycle, LMP, whatever, or she has not resumed her menses within the month of sterilization, but pregnancy test is negative. So if it is done, and if it's not done, what are the dates of menses, next menses, or bleeding or spotting, it is to be written here. For male sterilization, his semen examination undertaken on, because it should be done after 3 months. And if the azoospermia is there, then it is considered as the 100% successful operation, and then only we give this certificate. Strigoid not available. He is therefore certified to be sterile. Okay, this is to be given after. So follow-up schedule: male 48 hours. Any complication, any bleeding is there, because it is very easy, because only just subcutaneous, there is a spermatic cord, we need to cut it and ligate. Okay, within 5 minutes we can do that. 7 days for follow-up, no any infection or anything, and 3 months for the certification and azoospermia. And for female, any bleeding or spotting in 2 weeks or the next menstrual cycle, she must come. So this is a pro forma given by the government of Maharashtra. It is very good book produced by Rajya Kutumba Kalyan Karyalayya Pune, RCH office Pune. They have produced this, and they have given free of cost to everybody, for all government setups and for all private setup also, those who are conducting tubectomy and vasectomy. This is very good schedule, because they have given the schedule here, how to proceed. These are the instructions to the patients, and these are the follow-up. Then first visit 48 hours, 5 days, 7 days. I'll give you the then you can have photographs. This is a book which we give. Then this is prepared by, this is the schedule, how to go. First come, then counseling is done by the counselor, then the investigations are done by the pathologist, then everything is seen by the nursing staff, then it is seen by the consultant who is doing the surgery. Surgery must be done after looking at the papers only, because many a times it had happened that surgery is done and the consent is incomplete, or consent has not taken and the complication took place. Likewise, it should happen. So every surgeon must confirm that everything is there. Fine. So this is the general instructions, and these are the follow-up schedule, everything. And this is the information. So reward for sterilization. I don't understand why there is a discrimination. Female sterilization by any method. Below BPL, it is 600 rupees, and above BPL, it is 250. Very less, very less. It should be more than 5,000 at a given cost. I must insist that it must be more than 5,000. Facilitator for the female sterilization gets only 150 rupees. It is very less. But male sterilization, 1,451. Why? I don't understand. Because they are reluctant to do, that's why it must be more than female, but it is a discrimination, clear cut. And the facilitator for male gets 200. It should be more than 5,000. My personal opinion. Okay. Compensation of MISAP, very, very important. Failure of operation. Then what is the remedy? Free reoperation and MTP free, and rupees 30,000 from Government of India if your OT is recognized. Fine. If complication, only infection is there, it is not failure, or the pregnancy is not there, only complication, infection, pus pockets, or every complication, they get only 25,000 for hospital expenditure and free of cost treatment. And if the death take place, then 2 lakh rupees is the compensation. Consent form duly signed itself is the form for insurance by government insurance agency in the operation theatre, which is recognized by civil surgeon. They are mandated. So that the end of my lecture. So again, thank you all stalwarts, and thank you my sister Komal. So I give the best wishes to Komal and Mala Madam for their endeavor in the Foxy. So thank you very much.
Thank you, Dr. Ajay Mane sir. It was a very wonderful and a very crisp lecture. I request Dr. Kiran Sinha ma'am to give her expert comments.
Thank you so much for giving me this chance to be a part of this organizing, to be a part of this very important CME on this World Population Day. As I belong to Uttar Pradesh and was retired from public hospital, so want to share some very important point which is to be definitely taken care of. Here, when I was in the service, then there used to be a form. Now there is a booklet, जैसा कि अजय माने सर ने दिखाया है. The Uttar Pradesh government has also issued a booklet, and this booklet is very thin. All the papers there are 13 papers, and all of them are plastic coated, so nobody can destroy it or throw it. And this contains 13 pages. Each and every minor details are there. It is to be filled by the patient, motivator, medical officers, surgeons, and even anesthetist as well. There is medical record and checklist also for both male and female sterilization, in which even the menstrual history, obstetric history, even the contraceptive history, all is mentioned in detail, which is to be filled by the patient, as the patient must know that she knows all other methods of the contraception also in spite of this permanent sterilization, and she is not posed for it. And this medical history has got every detail. Ek infection, but you have to tick only yes or no. You have to go on ticking, and you cannot miss even a single entity. Because when there are so many patients, जब हम लोग जाते थे 500-700 cases करते तो उस समय it was not so easy. लेकिन अगर अब आप है तो बस you have to just question करते जाइए, yes or no tick करते जाइए. And there, in the examination also PVPS is there. Even you have to note down the cervical erosion also, as Dr. Ajay Mane sir has mentioned. The date of LMP is very important. Suppose if the patient has come on the 5th day, it means that she is not pregnant. Suppose if she comes in between that thing, so you never know that she might have conceived also. So the next LMP date, next menstruation date is to be mentioned on that form. And the after post-operative monitoring must be done up to 4 hours after sterilization. जैसा कि आपने अजय माने सर ने बताया, 30 minutes, 1 hour, and at the time of discharge, most of the time the patients are being discharged on after 4 hours if no complication is there. and what is the condition of discharge at the patient. And the lab investigation is also important. 3 investigation, at least hemoglobin, urine for albumin and sugar, और डिटेल हिस्ट्री तो उसमें सब आपकी है, ये वो आप ले लो. डिस्चार्ज स्लिप में इन विच ईच एंड एवरी important point is written in Hindi also. और जैसा कि अगर आपने, if you have done male sterilization, then you have to call the patient definitely after 3 months to get his semen examination done. If it is azoospermic, it means that now he is a sterile person. And you have, by that time, you have to tell in detail and you have to write in Hindi even कि आप इस समय अगर if you want to have contact with your wife, you have to use condom. Because I have attended at least 3 or 4 cases in the court of male sterilization where the wife became pregnant and the उसके husband ने उसके ऊपर चार्ज लगा दिया कि ये तो ऐसी औरत है वैसी औरत है. I have attended 3 cases in the court about it.
Dr. Kiran Sinha, I think your points are so lovely, but we have Dr. Rishikesh Pai sir who has joined. So,
एक मिनट और उसके बाद जैसा कि आपने बताया कि 2 लाख डेथ में मिलेगा, 8 से 30 डेज के अंदर 50,000. If the tubectomy is failed and pregnancy is conceived, 30,000. But everything you have to report within 90 days of any. If you are reporting after 90 days, then you are not a claimant for that thing. Thank you so much, Dr. Ajay, for such a lovely talk. Over to you, Dr. Komal.
Thank you, Kiran Madam. I think your inputs were so lovely. And we have a real honor. Our President Foxy, Dr. Rishikesh Pai sir has joined. And sir is really, I think we have spoken about him a lot. And he's really a pride of India. Like he's made us proud nationally and internationally. And currently doing such wonderful work as President of Foxy. He is the founder and medical director of Bloom IVF. And yes, sir. Sir is here.
Basically, thank you for calling me on this auspicious occasion of World Population Day. Basically, our population, as you know, we have become the, first of all, let me say, pay my respect to the people who are there. Ajay, our Ajay is there. Ajay Mane, our next incoming Vice President, Dr. Pardesi, I don't know whether Rajendra Singh is there. And then all the senior people are there, Dr. Mala Srivastav, Dr. Komal Chavan, our dynamic past chair and now. And then we have got Dr. Vidhu, Dr. Ritu Khanna, our food, medical, surgical equipment committee chair, very dynamic, doing a lot of work in vaccines. And Dr. Asha Jain, who is also a very dynamic person, Dr. Upma Jaiswal, Dr. Shakuntala Kumar and Dr. Kiran Sinha and Dr. Alpana and many are there. I can't make out the name. Dr. Banita. So basically today is the World Population Day and mainly it was it was started on 11th of July 1990. And this year's slogan is unleashing the power of gender equality, uplifting the voices of women and girls to unlock our world's infinite possibilities. That is the slogan of this year in 2023. And as you know that our country has now, if you look at the world population, it reached 1 billion after many thousands of years. Then in 200 years, it increased to 7 billion. Then in the last 10 years, it became 8 billion. Then they are projected to become 8.5 billion by 2030, 9.7 billion by 2050 and 10.9 billion by 2100. And if you look at the world's total fertility rate, now it is at 2.5 and life expectancy is 72 years. So, the life expectancy has gone up and TFR has gone down, but it's still quite high. So overall, because of that, the population is still rising. So it will probably stabilize. Many people feel that it will stabilize by 2050. In India, stabilization will come by 2050 or between 2030 and 2050, but mostly it will stabilize in India by 2050. If you look at the population, India has got 1.42 billion population. China has got 1.42 also, but India has just crossed China just 2-3 months back. I was interviewed by French television, not as Dr. Pai, but as Foxy president. They came all the way from France and they were asking me what are the implications of this increase in population. So I was telling them that our country, it is good to have a large population, but at the same time, it is still bad because, there's a lot of consumption and all that leads to climate change. See, yesterday also we had a lot of rain, etc., etc. So it's a big problem for the country. Large population is not an economic advantage. I don't agree with it. A large population is, and we are going to be the third largest economy in the world. But at what is our overall, because of the population, even if we become the third largest economy in the world, we still are going to be very poor. Many of our people are going to be poor because the dilution, the number is the problem with our country. And if you look at USA in comparison, they have only 340 million. So, and a large landmass. So even China, even if it is nearly the same as our population, they are a landmass which is 3 to 4 times larger than ours. So the density of population is very low in China also. If you look at our National Family Health Survey number 5, the total fertility rate has gone to 2. So we are now at a ideal optimal rate, but even then some of the UP and Bihar states and all have still got higher total fertility rate. The total fertility rate for example, in UP is 2.4, Maharashtra is 1.7, Kerala is 1.8. And if you look at the major family planning usage, still 60 to around nearly 40% of people, they use family planning method as female sterilization. So permanent method is still the most important female sterilization method. However, IUCD is around between 1.5 to 4%. Manipur, the higher utilization is there, but overall, if you look at the states of Maharashtra, UP and Kerala, their IUCD rate is nearly the same, and hardly any vasectomy is there in the general population. So that is the situation at present. As far as FOXI is concerned, for me, it is very important. We have in Delhi, as you know, we had done roundtable meetings, and we had 8 or 9 roundtable meetings. Already we had a meeting of roundtable on family planning, contraception. So some of the initiatives we have planned is that we will aggressively, because already FOXI has done the FOXI FIGO PPIUCD program, but we will aggressively market. We'll go for the long-acting reversible contraceptive program. We are about to launch that program in our country. Implanon program will be launched. I don't believe in utilizing all other companies. I am totally FOXI believer, and we don't really need any money from anyone to do our work. So we will launch the family planning program in a very aggressive manner. Will promote also. We must at the same time see that our sterilization program is also maintained. We have neglected the sterilization program, safety of sterilization. All our laparoscopic surgeons are busy trying to get the fibroids out, but no one is busy trying to do the sterilization, which once upon a time was very important landmark. So we have, as gynecologists also, we have shifted from our goalpost, and that is not good for us. In the olden days, our senior gynecologists used to have focus on sterilization, family planning, and now we have focus on removing fibroids, removing the uterus, all that. So we have to bring back and shift back our focus. In our country, family planning is very important, and we gynecologists are the custodians of that program. We have to implement it very effectively. So these are certain things I would like to give you a perspective of, and I hope that I'm sure that Komal and Ritu, who have done this program today at the ground level, have done a good job, and they will bring this in perspective. So thank you, Komal and Ritu, for calling me here, and thank you, Dr. Rajendra Singh Pardesi, for associating AMOGS, which is one of the most important premier state associations of our country. I am very grateful to all of you and wish you the very best. Thank you.
Thank you so much, sir. I think your vision is par excellence. The way I think you have the vision, it will definitely take us in a very long way. We really need to introspect our own practices, and that is so important. And today only in AMOGS, with the help of the Family Welfare and MT Committee, we have launched one survey just to know how the health practitioners are addressing contraception. And that survey is not specifically for the gynecologist, but for all the health care workers. be it the paramedical staff or anybody, because it is not the only responsibility of gynecologists to motivate people for family planning, because people go to other specialty doctors also and nobody is sharing the burden. And that was the idea, that how the staffs are motivating or how the hospital workers are motivating. And that is the idea behind the survey. And the link I have spread in WhatsApp groups, and I will be sharing it in the chat box also. So requesting all to please participate and let your people participate and genuinely let us know what is the response, what is the inclination, how much, in what areas we need to work. I think that will be more evident by that survey. So thank you so much, Dr. Rishikesh Pai sir, for joining.
Thank you so much, sir, for giving us your blessings and amazing vision. So when we listen to you, we really feel we've got so much to do and so much to do. And you keep taking us, and it's a long way to go. Thank you so much, sir, for giving us all that inspiration.
All the best.
Thank you, sir.
Okay.
And over to Vidur. I think she had to give her concluding and remarks and all.
Yes.
Good evening to all. And thank you, Ritu, and everyone for giving me a chance to come here. And yes, as our president has already said that, we should be tickling our minds that we need to tell our patients how to take care of our population. That's the Foxy's already started Save the Uterus. So we should save the population also as a motto. And thank you, Dr. Ajay, for giving such a concise and crisp talk on how to document our work so that we don't land up into any medical legal hassles. And I think so it's very clear what we need to do in our practices and what we need to change. Thank you once again.
I congratulate Dr. Ajay Mane sir for giving a crisp insight into documentation of sterilization. And it was a great opportunity to listen to you, sir. Thank you very much.
Thank you, madam. And thank you, Komal, and thank you, Ritu, ma'am.
Thank you, sir. There were such clear points, it all went inside, sir. So we've captured a lot of things from you, sir. Thank you so much. Thank you, Mala madam, Vidur, and Kiran.
Thank you.
So, thank you all the chairpersons and Dr.
With your
Ajay.
permission, we start the second session now.
Yeah.
So it's my pleasure and privilege to introduce the chairpersons of the second session. We have with us Dr. Sushma Gupta ma'am, who's the president of Agra Obstetric Gynec Society. She's the director of Akanksha Test Tube Baby Center, Agra. She's a consultant at Dr. Kusum Gupta Nursing Home, Agra, senior gynecologist practicing in Agra for the last 25 years with a special interest in gynec surgery. And she is also an active social worker. So that goes very much in line with what Dr. Rishikesh has just said. Then we have Dr. Banita Sahai ma'am. She was the president of Jamshedpur Obstetric Gynec Society, director of Sahai Clinic. She is a faculty in MGM Medical College, speaker and chairperson in National Foxy, published papers and member of Breast Committee 23-24, member of Food and Drug Committee 22-23, and has an interest in fertility and oncology. Welcome, Dr. Shakuntala Kumar. She is MD of New Life Hospital, Delhi. She's a visiting consultant, Fortis Hospital, Shalimar Bagh and Apollo Cradle Hospital, Motinagar. Vice Chairman, PG DCMLS DGF, Scientific Advisor, DGF North. She has been the organizing chairperson of Akriti Medical Legal Conclave 2023, organizing secretary of many conferences, recipient of President Abdul Kalam Award, has 15 publications and has published training modules for paramedical trainees. She has been a speaker of faculty in more than 2,000 national and international CMEs and has organized several youth awareness camps, breast cancer awareness programs. Presently, she's a FIAOG, FICOG, FIC-MCH, life member of IMA, AOGD, IFS, DGAS, ISAR, past secretary and vice president, DGF North, past chairperson, Adolescent Committee, AOGD, executive member, Adolescent Committee, AOGD, ex-joint editor, Delhi ISAR, and ex-treasurer, ISPAT Delhi chapter. Welcome, Dr. Shakuntala Kumar. And now I request Dr. Sushma Gupta ma'am to please introduce our speaker for the evening, Dr. Komal Chavan.
Thank you, ma'am, so much. And it is my proud privilege here to be able to introduce Dr. Komal N. Shravan. She is such a dynamic young lady, and I am really honored to introduce her. Am I audible? Hello?
Yes, ma'am. Yes, ma'am.
Yeah. Okay. So,
Yes.
Dr. Komal N. Shravan. She is the Medical Director, Shravan Maternity and Nursing Home. She is the Senior Consultant and a DNB teacher and Unit Chief at V.N. Desai Hospital, Mumbai. She is ex-honorary Professor Dr. R.N. Cooper Hospital and HBT Medical College. She is MD, DNB, MNA, AMS, FCPS, DGO, FICOG. She is a diploma in reproductive medicine. She is chairperson FOXY Medical Disorders in Pregnancy Committee. She is zonal coordinator for FOXY president.
I
She
think
is
Dr. Sushma ji, I think
she has so many credits to her name that it would be, not possible to list all of them, except that may I mention that she's also in the editorial board of Journal of Global Obstetrics and Gynecology. So with so many prizes and so many awards and such a well-known figure, I would invite Dr. Komal for the next session.
Thank you so much for the warm introduction, and I'm really honored and happy to be part of this program along with Dr. Ritu. We have shaped the program very well. It is going very nice with blessings of all the seniors and all the chairpersons. The last session of Dr. Ajay Mane was so lovely with documentation, because that is the contraception. What is most important is the documentation. And it was such a lovely session with Dr. Malaji, Dr. Kiran ji. I think their comments were fabulous, and Dr. Vidhu. It was really an insight and an eye opener for all of us. And now what I'm going to talk is something very, very practical. It is postpartum contraception. And we talk about postpartum contraception all the time, because that is the time where we need to target our women and get the maximum contraceptive. They are more susceptible, responsible, and that is a time where we need to tell them that contraception is important. And we have spoken about the theme of the World Population Day 2023, that is unleashing the power of gender equality. And we are really moving ahead with this motto. This is a survey which I had just said. I will share the link in the chat box later. So I'll begin with a quote from Hillary Clinton. You cannot have maternal health without reproductive health. And reproductive health includes contraception, family planning, and access to legal and safe abortions. And contraception is very important. India is the populated country, has already surpassed China's population. The growth exponential, I think Dr. Pai said how it is estimated to grow and then stabilize it later into after 2050, almost 2000. So I think that is a very long time. And by that, it will be real big population which we are going to have. Every state of India is compared to almost a country. You can see in this chart, and that is the burden of population which we have, and the responsibility lies with all of us. So my topic today, postpartum contraception. By definition, initiation of use of family planning during the first year after birth. So traditionally it was 6 weeks, and now there is an extended period, that is the first 1 year. And this is by WHO. WHO has said that postpartum contraception is to plan an unintended pregnancy in the first 12 months after childbirth. And what is the scenario in India? Approximately 27% of the births occur in the 24 months after the last childbirth. And 34% of this birth really are because there is lack of unmet need of spacing and any contraceptive practice. When we ask them, they really have not followed any method of contraception. And these are the unintended pregnancy. Today only, I had a patient who was a previous LSCS. Just 15 months, she came with a scar tenderness, and we had to take with a short interconceptual period. So that is the awareness these people have, and they do conceive because they are reluctant for contraception. They are reluctant. They say that I had my child, pehle wala bachcha bahut late hua tha, to mujhe laga nahi hoga. So they are hesitant to start the contraception. So that is a scenario in India. So what are the timing? Post-placental, within 10 minutes of delivery, immediate postpartum, up to 48 hours. Then 6 weeks, that is when they come for follow-up 6 weeks after delivery. Extended 6 weeks to 1 year. And we need to really start counseling these patients, and opportunities are endless. The patient comes maybe in a gynec OPD, or she's coming to your antenatal OPD, or she comes to a postpartum care for suture removal, or she comes for neonatal vaccinations. So these are the opportunities, and every opportunity should be targeted. The importance is that if postpartum contraception is followed effectively, even the maternal deaths are reduced. You have less amount of anemia. You have less amount of preterm birth, low birth weight. You know, everything, all these are the nutritional problem which is there is all going to be really, really beneficial. So what are the key contents? That is spacing, then lactational amenorrhea. This is very important. But most important is discussing and choosing a family planning method for a couple. A couple communication is most important in the first month postpartum. Barriers are there everywhere. We know the barriers which is there because of the social factor. Then there can be because of the cost factor, because of the ignorance factor, because of familial factors, and barriers to take. The cafeteria is really full with so many choices, but patient needs to choose. And when they choose, we need to make a choices how effectively we can have a contraception which is most effective. So when we see the effectiveness, the implants, the sterilization, vasectomy, IUD are quite effective methods, whereas the other methods are not very effective. So we need to make it effective by using it optimally. So the WHO has an eligibility criteria also. When you're choosing for mothers postpartum, they all may not be having the same eligibility. They may be high-risk mothers also. Some having diabetes, some having an PPROM, or some having an hypertension. So, and some may have a difficult delivery. You know, they may be landing up with a IUFD because of some problems. So every patient needs a different thing. And that is a problem wherein we have this eligibility criteria. So category 1, there are no restrictions. 2, advantages generally outweighs the risk. 3 is risk generally outweighs the advantage. And 4 is too risky. So when we talk about all these methods, what commonly comes into your mind is the lactational amenorrhea method. And this is a good method if properly practiced, but properly understood. Because patient feels that they need to, that giving water or anything is also okay, but no, only and only exclusive breastfeeding. There should be no menstrual bleeding, not even a slight bleeding if the patient has not got her menses. And this is effective only the first 6 months. And anything you feel that it is not working the way all the 3 points are there, then this method is not going to be effective, and you can definitely get pregnant in this lactational amenorrhea. Then the common method which everybody tells for spacing is a postpartum IUCD, and it is a long-term reversible method. Alternative to tubectomy, because we talked about tubectomy, how documentation, everything, and really a good method because it can actually is a reversible, and it is also long-term, that's 5 years, or even you have longer acting IUCDs, and very convenient time for spacing postpartum because it is very safe. There are not much of side effects. Even the MTP rates decrease later on. So, and it is not going to impact the lactation, the breast milk also. So the advantages also are endless. What is only thing is the inhibition or the social stigma which the IUCD carries. It is very, very sad to know. Government of India has even have Property 380A in the PPIUCD program, and this is how the ring forceps can be introduced postpartum. So this is called as a PPIUCD forceps, and we can hold the 1T of the forceps and you can slide it inside the uterine cavity. This is a simple method because the cervix is open, post-placental insertion. It is really, really beneficial. So this is how it goes. You have to grasp the anterior leg with the forceps with your sponge holder, and do not close the ratchet of the forceps. Just hold it gently, give a little traction, and insert the forceps inside with an IUCD and place the IUCD in the cavity. And then you can remove the forceps and you can judge. You can keep the threads long also because the uterus is going to involute. So threads also will become small, and dependingly later on you can cut the threads. So this is alternatively you can hold it if you don't have the finger. You can hold it between your index and your ring finger. You can hold this first and between your third and the second and the third finger, and introduce with your hand till the fundus. Confirm that it is just below your fundus, and then remove it, and then the threads can be left below. So this is how it is there. And later on, you need to check the threads. Maybe you can call the patient after a few days after delivery, or if you feel threads are very long, then you can cut it that time, but don't cut it too short. Then coming to the cesarean section introduction. So PPIUCD insertion in cesarean section are really a good thing if you're doing a section for any patient, but if you're doing a section for previous scar uterus, doing this procedure is really beneficial. A very simple method. It can be performed during the operation. There is nothing extra procedure you have to do. You just have to put the IUCD just below the fundus. Mind you, you don't have to poke the threads and remove it totally out. Just put it near the internal or the cervical pores, and you can close the hysterectomy incision in the standard way. And this is a video of a post-placental insertion in a cesarean section. Yeah. So this is how the IUCD is loaded in the same way conventionally how you load it. Then you have this inserter. You know what is the size, the marker, and then this is an open incision. Half of the incision is closed, and then you just introduce gently. Again, the withdrawal technique which comes in. You place the copper teeth, and you just go down and don't poke it too much. Just place the threads near the internal pores. Don't go below because there may be chances of infection, and you just remove it out. It is a no-touch technique and very simple. And commonly, I'm telling all my doctors, residents, everybody to do this postpartum IUCD during cesarean section. Then coming to the postpartum pills, definitely breastfeeding is there, and we don't want oral contraceptive pills because of the venous thromboembolism affecting on the breast milk. But definitely, which are non-estrogen containing pills, that is the non-hormonal or progesterone only pills. These are something which are really the options for breastfeeding mothers. And ACOG and WHO also agree that after 6 weeks, if woman is not breastfeeding, you can give them combined oral contraceptive pill, but not before that. And progesterone only pills, definitely they have a benefit with consistent ovulation inhibition, thickening of cervical mucus, and acts on endometrium impairing implantation. So you can give it in a continuous period also with no pill-free interval. The estrogen nature does not affect the breast milk, and it is very important. And drospirenone is one of the novel 4th generation pill which is available, and we can give it all even after breastfeeding, or even after an abortion, or even if patient who is having any high risk factor like thromboembolism or varicose veins or even anemia, these pills are relatively safe. Coming to the sterilization, I think it was spoken by Dr. Ajay Mane, and if the family is completed and you feel that this is most convenient option, definitely counseling is required, the pre-procedure counseling. Later on, they should not come for a reversal or a regret because there is a change of partner or something, or if their children are too small and some child expires and they really come for reversal, or sometimes they feel that that there can be a post litigation. A patient can come and say that that there is a post ligation syndrome and patient feels very depressed or sad or something. So they should not have a long-term regret, and that is only covered if you do adequate pre-procedure counseling. So very important, and the partner involvement is very important in sterilization. Subdermal implants becoming very popular today in Mumbai, with Anaita Chavan as a president of Mumbai Obstetrics and Gynec Society. We have an Implanon training today for everybody. So I think training is required. It is a very popular contraceptive in the Western world, but Implanon and Implanon NXT are the 2 types. And the insertion is a very simple procedure, but you require a little bit of training in local anesthesia. With 1% lignocaine and adrenaline, you can do it. And you need to place your hand in a parallel way just above your head. And we need to insert 8 to 10 centimeters up the arm from the medial epicondyle. Subdermal, it is implanted with an applicator at 30 degrees to the skin. And women can actually palpate the device. And after palpation, you know that the device is in place. And the advantages are definitely there. Also, when we talk about the DMPA, Netin DMPA is an injection that everybody says they want to take an injection post-delivery. And Depo-Provera is something which we are giving to our women, and 150 milligram every 3 monthly. They can take on upper arm or a buttock, commonly known as an antara. But the problem is the menstrual changes. It becomes very irregular. There can be amenorrhea, headache is something which is very bad, dizziness, changes in mood and sex drive, and it takes a time for fertility to return. That as a drawback, but patients may discontinue if they have chosen this option. So you need to counsel. Everything can be overcome by counseling. This is the Depo-Provera subQ, which is a newer injection, which is also available. But what is most important is making a decision at the household level, involving the family, creating a supportive environment, the partner, the male involvement, because every time when you will ask and counsel a patient for contraception, they will say, I will go and ask my mother-in-law or my jethani or husband. So that becomes very important. So both needs to be counseled. And this is how the summary of what we spoke, all the methods from the lactational amenorrhea till the vasectomy. I think vasectomy, which the point also was raised that by Dr. Kiran Sinha, that the compensations and everything is not very uniform for vasectomy and tubectomy. So all the options, including vasectomy, needs to be explained to the patients, and counseling needs to be done. So what I consider is a postpartum contraception is not considered as a vertical program, but rather as an integrated part of existing maternal and child care and family planning efforts. So it is actually a comprehensive program, and we all need to work, target the woman at every level. This is the summary of all the charts, the policy level, the individual level, the hospital level, the physician level, all barriers we need to overcome and try to improve on this unmet need, which is highest in the first 1 year post-delivery, in spite of 95% of the ladies actually wanting to avoid pregnancy, but they don't speak up. They only come next time when they are pregnant and they realize that they have done a mistake. So we really need to counsel them and spend time with them. And it is a unique period of life, adding more reasons for not using contraception, that is a postpartum, and spacing for minimum 2 years. If you give them a good choice, it definitely improves the maternal health. You don't have the maternal health going down, the medical disorder or the problems with the mother can be taken care. And because of the spacing, if there is a next pregnancy, it improves the fetal outcome also. So we give a healthy mother and healthy baby. And I will end with a quote from Atul Gawande. You may not control life circumstances, but getting to be the author of your own life means getting to control what you do with them. And so the control should lie with our females, and our females should use contraception very, very wisely. Thank you so much for your patient hearing. And in my humble appeal, support me for the post of Vice President of FOGSI from the West Zone. It is an e-voting from 1st August to 10th of August. If you have not updated your data, please go at member.fogsy.org, update your data, because that is your opportunity to vote. We all need to be supportive in this election process, because we are your candidates and we are always approachable to you and available whenever you need it. So with that note, thank you so much for your patient hearing.
Thank you so much, Dr. Komal. It was really a very excellent deliberation on every part of the postpartum you have touched. The only thing I can add, that is the thing is that we get a window period of antenatal time. At that time, we can counsel both the couple and even the family for the postpartum and give them basket of choice, what we can give them. So that it's they make themselves mentally prepared to get postpartum contraception, and it will be not difficult for us. At the outset, I congratulate both of you, Dr. Ritu and Dr. Komal, to organizing such a wonderful webinar and just giving me to participate in this wonderful events and as a chairperson, and just to share with the stalwarts. Thank you so much. Lastly, I want to add a simple word that Dr. Mane has told about the remuneration amount of the male and the female. There is a difference
it should be increased because everything in our country, people wants free or something, and they will be motivated only if they get 5,000, 6,000 for the sterilization and all. Thank you so much.
Thank you so much, Dr. Komal. It was absolutely wonderful. There are a few things that I just want to highlight. I think you have covered everything very beautifully. But when we are doing Implanon and we are removing Implanon, we have several international patients coming to us. Please remember that in Africa, they have 2 rods. So when you're removing a rod, it is not just a single rod, you have to remove 2 rods. So we've had this opportunity of, just removing 1 rod, and on the other day, the lady comes back with 1 more rod, in her arm. And it was quite scary. But then when you just contact the company, that it comes by the name Jidel, and it has got 2 rods. So just wanted to highlight that. And secondly, when we are doing PPIUCD, the removal, in one of the patients, we encountered the transmigration intramyometrially until the cornual edge, and it was so difficult that we required a ureteric forceps, to remove the IUCD. So, I mean, it was a big nightmare, but then these are the things that we need to kind of remember. But I think the postpartum contraception is the need of the hour, and you have beautifully highlighted all the facets of it. So congratulations to you, and wish you all the very, very best for your future endeavors.
Thank you so much, Dr. Shakuntala. Yeah, postpartum contraception, IUCD, what you highlighted, we do it very common. We have a program in my hospital also where I run. We are doing a lot of postpartum IUCDs, but the only things, these are very few patients which come with that the property is expelled or the IUCD is expelled, spontaneous expulsion or migration. But many patients are benefited, and really, even if the threads are not very short or something, we need to just counsel them that it is there in place. I think that also works. So these are some few things we have to look after, but I think that should not stop us from motivating patients to choose the contraceptive option. Yes.
True. Thank you.
Thank you, Komal. That was a fantastic presentation. I think very crisp, so many clear messages that we really got, and we were fortunate to hear you, and we wish you very best for your candidature for the Vice President, and hope to have you in flying colors. And wish Mala Madam also all the best. And thank you to our chairpersons, Dr. Shakuntala, Dr. Sushma, and Dr. Vanita. I think it was a very, and I really loved, working with Komal. We got many times to work together. And in a very, very short time, we had the vision to put this program together. So thank you once again to AMOG's Family Welfare and MTP Committee also to join hands, and all of you just came at a go. Thank you.
Thank you so much.
Thank you, Dr. Ritu. Am I permitted to add a word?
Yeah. Yeah, sure.
Actually, Dr. Komal, here what is happening, they put in the PPIUCD and they don't actually counsel the patient. And the patient, once she delivers, and then maybe she has a prolonged bleeding or something, she goes to some other center and has it out. Now, she doesn't even report that she has it removed. So I think the most important thing here is the antenatal counseling and, explaining what is going to happen. Because otherwise the data is there that we have put in so many IUCDs, but the patient has it out.
You don't
have more than half the people just walk out of the hospital and have it removed.
Yes, because why? Because it has not been counseled, and always tell.
Exactly. That is just what I wanted to bring up.
Yeah, we have a program, but I say don't go, be realistic. There is no need to just show figures. So we make it a point to tell every patient and inform and put it. So that shows
this is not actually for you. This is for all those who are listening.
Everyone.
Everybody should do that.
Everyone.
Tell and put.
Yes. Tell and put. Yes.
So thanks a lot for this beautiful session. And now, with due permission, we proceed to the third. Dr. Ritu?
Yes, of course.
So may I have the CVs, please? Dr. Vidya hasn't joined, I think.
Yeah, I think she couldn't join. She was into an exam or something. So
you again would have to introduce the
so
panelists. So we have with us Dr. Ritu Khanna ma'am, who is the moderator here, and she will be taking the panel.
Yes. We'll just introduce our panelists. We have with us Dr. Dhanalakshmi Parumalsmi, who is a consultant obstetrician, Kandasamy Hospital, Kottaram, Kanyakumari. And I think she's a very, very hardworking, very humble person. So welcome to you. We have can we have the next CV, Dr. Varsha Lade, who is the president, Nasik Obstetric Gynec Society. She's a zonal coordinator for EMOGS, and she's the past organizing secretary for NOGS and a director of Prayag Hospital, Nasik. And of course,
Sahiti, please, the next CVs. The next CVs,
Dr. Udaya Banu, who is a consultant, Chilamal Hospital, Anju Gramam, Kanyakumari district, Tamil Nadu. She's very, very skillful, very enthusiastic, and welcome to you. Dr. GB Madhavi, who is the past president of Karimnagar Obstetric Gynec Society. She is the professor, OBGYN department, CAIMS Medical College, fetal medicine specialist, and has had an advanced training in gynec ultrasound, and very, very courteous and very humble. We have Dr. Upma Yadav Jaiswal, who is the director, Swastik Marigold Hospital, Gorakhnath, Maheshara Maniram, Guleria Medical Road, and of course, the past physician in charge of the FPI Mumbai, and with special interest into obstetric ultrasound and IVF. So welcome, Dr. Upma. We have Dr. Swati Gupta, who is the ex-assistant professor, Rama Medical College, and ex-director at Medcare Hospital, Kanpur. And her fields of interest stand as high-risk pregnancy and infertility, very energetic and very dynamic. So with these words, I think we move to our panel discussion. And Sahiti, can I have my slide share? You'll have to stop share for me to do the slide share. Yes, thank you so much. I'll do my slide share for the panel. 1 minute. Yeah. Just a minute, 1 minute, just give me. ये नहीं पैनल उसकी पीपीटी देखो स्लाइड शेयर वो है ना अपने पैनल जी इसमें दिखाई नहीं दे रहा जल्दी करो नहीं आ रहा I can't see my slide. पता नहीं उसको बंद करो इसको मिनिमाइज करके दोबारा करके खोलते हैं स्लाइड को बंद करके खोलें just a minute, I'm just doing my slide share little. I think minimize slide share ये है क्या I can't see my slide share. Yeah. I checked it earlier, but not able to locate the slide. You know, option ये नहीं आ रहा. ये बंद भी नहीं हो रहा ना ये आ गया हाँ yeah. Share. Full screen. So are you able to see my slide?
Yes, ma'am.
Sorry for the delay. And yeah, so when we start the panel, and we have all our esteemed panelists with us. So the first question to Dr. Dhanalakshmi, it goes as this is Mrs. X, who's 25 years old. She's married for a year for preconceptual counseling, and she's now planning to conceive in the next 3 to 6 months. So is it that you would go in for any specific history, any counseling that you want to do for immunization? How would you move forward with this patient?
Thank you, ma'am. I would definitely like to take a proper history from her. Her health status is most important. I'll ask her about her previous immunization status, what her childhood immunization, and I will take a history to look for any immunocompromised status in the patient, whether she has any renal disease or liver disease, HIV, or any respiratory conditions like asthma or heart disease. And I will ask for her travel plans for the next current 2 to 3 months, so that if she's going to any endemic area, I can consider vaccinations.
Yes.
Also, I have to ask her about her whether she's having a fever or any health condition right now at this time when I'm counseling her for vaccination. And I also have to consider whether there is any epidemic or pandemic going on at the time that she has come for counseling, and counsel her for that also.
Yeah.
We also have to ask her about any allergy during her previous vaccinations.
Yeah. So thank you so much, Dhanalakshmi. I think it took a couple of seconds and maybe a minute to find out all these questions from her, and was so happy. We hardly any of us are there who would devote so much of time to dig in that much of history, and that was the importance why we put up this question to you. So my next question, so this is the pre-vaccination conception schedule that we must all follow and vaccinate all our patients with this, and we all are aware of the schedule. So Dr. Varsha, when you're going to give a rubella vaccine, do you advise a rubella IgG prior to your vaccination? Is Dr. Varsha there? Dr. Varsha?
Yeah, good evening.
Hi. Yeah.
Good evening. Hello, am I audible?
Yes, you're audible. So do you do
serological testing for immunity to rubella actually is not recommended before or after the routine administration of the rubella doses. MMR, rubella vaccine or a combined MMR. Okay, fine. And in uncertain situations, like if she has taken few doses before, she or he, then in this situation, you have to do the serological testing. If woman is planning for any pregnancy in future, in spite of her serology, whatever negative or positive, we have to go ahead with the immunization. As well, if in some uncertain situations, like whether she has a history of natural immunity, and if then you can go ahead and think of not considering her vaccination.
Yeah. So thank you so much. Guidelines according to this, IgG rubella is not a necessity, as ma'am said, to do it, but in certain situations where she mentioned, you may like to do it. And of course, you've got Google savvy patients of yours who may also search and be coming to you. So Dr. Udaya, now do you choose rubella, or you want to do an MMR vaccine? What will be your choice and why?
My choice will be MMR vaccine, madam.
Okay.
I hope I'm audible. Yeah.
Yes, you're audible.
It gives protection for all the 3 diseases in the same amount of efficacy, both 97% efficacy, even in single dose of rubella vaccine, as well as 2 doses of MMR. So it's better to go for MMR,
Yes.
Buy 1 get 3.
And we also need to spread the message. We need to give MMR, and in a short while, and I think in many places, rubella is not going to be available too. So CDC emphasizes the use of MMR, and because the risk to fetus from administration of the live vaccines, and therefore the pregnancy needs to be avoided for at least 28 days. Dr. Madhavi, if she took MMR and then she became pregnant in the 2nd month, should she terminate the pregnancy? Dr. Madhavi?
Yeah, am I audible?
Yes, you're audible. I think we can keep the mics on so that saves time.
Okay, this MMR vaccine, this is a live attenuated vaccine. Ideally, it should not be given in pregnancy, or at least 4 weeks of gap should be given. But however, most of the time, sometimes they get that vaccination and then they realize they are pregnant. In such a situation, we should not advise termination of pregnancy for her, because the chances of the fetus getting infected post-vaccination is very low. But we have to make her aware that she needs to have a follow-up and get a targeted imaging to see if she has any problems going on with the fetus.
Yeah, so thank you so much. I think pregnancy should be ruled out prior to immunization, and immunization history is a part, and it should be a part of the first antenatal visit of our patients. Live vaccines, the risk is largely theoretical. So if taken and conceived, just as ma'am said, the vaccine they should not undergo termination for teratogenic risk. So, Dr. Upma, do you also take or dig into history of a childhood measles or chickenpox, or you just go on straight away giving them the vaccines?
It is very important for us. Good evening, ma'am. It is very important for us to take a history of childhood measles as well as for chickenpox. Like if they do understand, or we can speak to them in the local language also, like khasra hua tha ki nahi, ya fir mata to nahi nikli thi, choti mata. So they understand this better. And it is very important for us to take this history. And if there is no history or the patient is very confused about the vaccination status, then we can vaccinate the patient and tell her all the
risks of the
if he gets the disease. It's very important to get the history.
Yes. So we do not want any of our patients to be suffering in the first and second trimester from the congenital varicella syndrome and also maternal pneumonias or any other. So it's very, very important to vaccinate them. Dr. Swati, what about HPV vaccination in the when your patients come into your clinic, do you spend time counseling them for HPV vaccination? By heart, do we really do them?
Ma'am, though pregnancy test is not required prior to the HPV vaccination, but since even if we give HPV vaccination in the preconception period, we have to defer the further doses till after the pregnancy.
Yeah, so it means that you counsel her that you take it preconceptionally. Is that?
Yes, ma'am.
Okay. Now, when you're going to give her any HPV vaccine, do you do a pap smear? Do you do a HPV DNA test before giving this vaccine? Yes or no?
No, ma'am. No, ma'am.
Any of the panelists want to say yes?
No.
No. So the guidelines, I think, do not recommend that if you have had, that you need to really do an HPV DNA testing. So we can easily go ahead, counsel our patients and give them a preconception vaccination. So all these vaccines before the pregnancy stand as a yes, and we need to counsel our patients to take this vaccine. So a question to all of you now, and Swati, okay. Now, if you missed these, 3 doses she could not take of HPV and she became pregnant, what does she do?
Ma'am, after the pregnancy is completed, we can give the further dose.
She took a single dose. Does she need to take all the 3 doses later on?
No. Only the rest 2 doses.
Okay, right. So we need to counsel her that HPV vaccines are not recommended. You missed this dose. So don't worry at all. After you finish with your pregnancy, you're delivered, you can just continue with your vaccination schedule as it is. So gender neutral vaccination. Dr. Madhavi Madam, what is your view?
Yes, ma'am. The prevalence of this HPV is quite
You're in
high.
favor of a gender neutral vaccination?
Yes, of course.
Why is it so?
That's because the incidence in males is also very high. And in a cohort where the cervical cancer in the women, the husbands also have 66%. So we have to catch them early and give the vaccination somewhere in the adolescent around 12 to 13 years is the ideal age for vaccinating them.
Right. So that means that Madam said the incidence of HPV prevalence in male is 26.7%. And it was found in the cohort where the spouses were suffering from cervical cancer, the HPV prevalence in male was as high as 66.7. And there is no screening recommendation for any anal, penile cancer and oropharyngeal cancer and all. So that was one need. We know HPV vaccination is increasing, and we know the increase per year, how many cases. We also know that the HPV transmission from the female to male is higher than that to male to female. But then if it is higher from female to male, why do we worry? We worry because the males experience a high rate of recurrence of these genital warts. At least one recurrence, 44%, and 22% get 2 recurrences. So the need was, if you look into this graph and you give only the female vaccination, it takes how much time? Look at the time. It is going to take us 30 years or so. And if you give both, this graph is going to come to a down level very, very fast. So that was a need that we need to go in for a gender neutral. Dr. Varsha.
We can reduce the HPV load in the population. HPV load will be reduced in the population, and if we suggest for one sex, many misconceptions and stigma may arise for this vaccination.
Correct.
So overall, if we suggest for the population, they are more likely to take the vaccine if administered to both boys and girls.
Yes. And but you need a lot of counseling for that to be done. So, Dr. Varsha, the future of HPV vaccine. Your comments on the single dose vaccine.
Yeah, the future of HPV vaccine for India is really, like, we all are proud to have Serum Institute of India in India, and now India, whole world is looking at India. September 22, we have launched a Sarvavac vaccine, which is a quadrivalent HPV vaccine. They have started it in 3 phases, and the target of 2030 is around 90% of Indian population will be covered with this Sarvavac vaccine. The schedule for these vaccines is, previously we used to use Cervarix and Gardasil. The schedule for all these vaccines is 1 or 2 doses for the girls of age 9 to 14, and 2 doses for 15 to 20. And in India, we recommend it till 45 age, 6 months apart, 3 doses if the woman is immunocompromised or having some other issues like immunocompromised status. But in India, we recommended it till 45. As I said, WHO expert group has evaluated 10 years. The evidence says that a single dose of this HPV vaccine has a comparable efficacy of 2 to 3 doses. So almost this is going to come in a national immunization program, because as it has been manufactured in India and the cost of the vaccine is very low, it would be included in national immunization program. So this is the future of HPV, a single dose with a low cost and a comparable efficacy of 2 to 3 doses.
Right. So thank you. That was fantastic, Dr. Basha. And I think if you have the single dose, look at the burden, and we're going to catch them at a very early age and just give them and just look at that. But yes, we need to remember, if it's an immunocompromised, give all the 3 doses, do not compromise. And the wonderful, they've studied the efficacy that one is equivalent to all the 3 doses. So Dr. Upma, when do you start giving your HPV vaccination? Is it 9 years? Is it 10 years? It is 12 years? What is the age that you started giving your HPV vaccination? What are the recommendations?
The HPV vaccination prevents new HPV infection. It does not treat the existing infection. So it is recommended before exposure to any sexual activity. And that is now clearly that it should start at 9 years of age.
Anybody else wants to differ for the age? You start at 11, you start at 12. All want to start it early. Let's look at the recommendations. The Advisory Committee on Immunization Practices and ACOG recommends HPV vaccination for girls and boys at the target age of 11 to 12 years. But yes, you can give it from 9 years. Why? Because it's been included as a part of the adolescent immunization platform. So yes, we are all correct with going for 9 years as the age. Thank you, Dr. Upma. Now, this patient was taking a quadrivalent vaccine. And she said, no, I want to switch on a nanovalent because I've just gone on the Google and I found that this is beneficial. So if she's given Dr. Swati this quadrivalent, does she need to repeat the whole course with the nanovalent?
So the quadrivalent vaccine includes virus-like proteins for 6, 11, 16, 18. And the nanovalent also includes VLPs for 31, 33, 45, 52, and 58, which accounts for another 10% of cervical cancer only in the females. So, so if she wants, then we do not need to repeat the entire dose. But if she's so much concerned, then after 12 to 36 months of the quadrivalent vaccine, we can give the schedule for the nanovalent vaccine if she's very much concerned. Otherwise, we can just go with the remaining doses of with the nanovalent vaccine.
Wonderful. So we do not need to, even by the recommendations, we don't need to repeat the doses. You can go and continue further with your doses. Now open to all. If she's tested positive for HPV DNA, can she still take the HPV vaccine?
Yes.
Yes. All of you are yes with it. She can go ahead. Yes. Yes. Why? Because it's going to at least offer the protection against all the other strains. And that's the reason that we were not even doing an HPV DNA testing before we were going to take her. So we move on to the vaccines in pregnancy. We know certain vaccines which have no evidence of fetal risk in the activated vaccines, bacterial and toxoid vaccines. And yes, recommended for all are the vaccines influenza and Tdap. Allowed in certain circumstances, we all know, and those which are not recommended, we all have an idea. And so I would not be going into the details of this. Now, my question stands to Dr. Dhanalakshmi. It's generally believed, that flu is self-limiting and complications in pregnancy are not common. It's just viral. Is that true?
I don't agree with that, madam. Pregnant women are at a highest risk for complications arising due to flu, especially during the seasonal flu periods or pandemics. There is an increased risk of severe illness, death, cardiopulmonary event, and a rate of hospitalization has also been found to be more, especially near-term patients getting the flu. And if the patient has an underlying medical condition like asthma, the risk increases even more. Also, even though viremia and the placental transmission of the virus has not been proved or is only theoretical, still the high fever and the maternal inflammatory response to the virus can affect the fetus. She can go in for a spontaneous abortion or a preterm birth or an intrauterine death. So the flu vaccine is recommended for pregnancy.
Yeah. So the prevalence of influenza in pregnancy is just similar to a general population. Pregnancy does not increase the likelihood, but influenza is more likely, as Dhanalakshmi said, to cause a very, very severe illness to the pregnant as compared to the non-pregnant women. Now, if we go into the list of the high risk, which can have serious complications, look at this list, the pregnancy less than 5 years, children, elderly, and all this goes. But WHO says pregnant women are the highest priority and therefore need the vaccination in any trimester. If you go to the hospital studies, look at the morbidity, the comorbidity that these patients have been suffering, the respiratory illness and everything, which goes on and on. So it is said that it's 2 times risk of maternal hospitalization and 5 times the risk for mortality and 10 times those were pregnant women with asthma and eventually also to the fetus. So Dhanalakshmi also said, yes, there is a need for influenza vaccine because that's going to increase, it's going to robust the immune response. It's going to robust the immune response. Yes. And so therefore it's going to prevent all the complications.
Vaccine works. There is a 90% reduction in hospitalization rate and 50% reduction in pneumonia if the person is vaccinated. And the benefit is passed on to the infant also for the first 6 months of life.
First 6 months of the pregnancy. So even the antibiotics, there was 45.4% reduction in the administration of antibiotic. The febrile episodes went down by 50%. So that was wonderful. And maternal immunity, yes, is the only effective strategy in a newborn because vaccines are not approved for use in infants younger than 6 months. So that was important. It's been supported by so many organization groups, and that's why it's a need of the hour to give an influenza vaccine. So Dr. Udaya, what is the ideal time that you want to give this influenza vaccine? What are the recommendations?
Actually, the recommendation is you can give the influenza vaccine anytime during pregnancy, during any trimester, but the ideal time should be the start of the flu season, preferably in the later pregnancy. Because, when you give the flu shot in the later pregnancy, the immune response is greater. So the chance of passing the passive immunity to the baby is higher. So preferably in the later pregnancy, preferably in the early part of the flu season.
Okay. So Udaya said that you should give it at the influenza. But actually, yes, you give it before the onset of influenza, but you really do not know when it's going to come. When it is going to, this flu activity is going to start, it's going to really vary. And there may be more than one outbreak over there also. So the recommendations ACOG says that you give it at any time during pregnancy, but yes, practically we give it after first trimester. WHO says anytime, ACOG says anytime, FOXI says after 26 weeks, but again, we are working on the guidelines to come it, and I think the fresh guidelines of FOXI that we are working on is, and being a part of it, would be to give it in any trimester, and IAP also says, yes, you give it at any time of the pregnancy. But we all know that we have a lot of safety data for the second and third trimester, but we have less of safety data for the first trimester. So practically, we avoid the first trimester for this vaccination. So Dr. Varsha, these flu strains, they are constantly changing, I do not know which vaccine to use. And what are the factors actually which are going to guide me to make a choice of my vaccine?
Yeah, flu vaccine, there are multiple viral strains, but in vaccination also, they have 3 types of vaccines like inactivated, then recombinant, live attenuated, as well as it depends on whom it is to be given, when it is to be given. Generally, a flu shot is commonly called as, it is recombinant flu vaccine, which is given to the pregnant lady. And then the factors which are considered the age. Then comes if the age, that means if you cannot give it to the child who is less than 6 months. You can give it to a person who is more than 65, and in pregnancy, any time of the pregnancy, preferably later months. And if she is allergic to the proteins, then you can go for a flu shot.
Yeah. So we have these trivalent and quadrivalent vaccines, and of course they are based on we have the hemagglutinin, and of course the coatings, that is the neuraminidase. Yes, it's based on that. And we have something as an antigenic drift. That is, there are mutations in the HANA of the same virus, and that results in epidemic. Then we have antigenic shifts. That is, resortment is occurring between the human and the avian virus, and that results into a pandemic which occurs. Now, there is a continuous change of circulating influenza viruses, and so many vaccine strains have to be done. So WHO is working on it, and it identifies all these antigenic variants. The vaccines manufacturing begins, and therefore the manufacture of the vaccines is being done accordingly. Now, we have so many major changes that have occurred with the years. And of course, so that is how we do the selection of, WHO does the selection of the vaccines. Now, Dr. Madhuri, do you like to use a trivalent or a quadrivalent?
Quadrivalent would be preferable because the main two virus strains that we have are A and B, and each of them have two lineages. So the quadrivalent would cover all the 4 of them, but the trivalent would cover only the 2 of A and only 1 of B. So I would prefer to have a quadrivalent vaccine rather than a trivalent vaccine, because it gives.
So Madhuri Madam wants to have a broader range so that she can cover everything. Yes, for trivalent we have strains, but for quadrivalent we have 2 B strains also. And we also know that there is a B mismatch which occurs when the circulating lineage does not match with the vaccine lineage. Now, if it doesn't match, what happens? The efficacy of the vaccine goes down. And it's been found that there is a co-circulation of the both lineages, B lineages, across the global surveillance that was done. So be it irrespective of geography, north, south, east, west, or central India, the co-circulation of both lineages have been isolated for patients. And that was the reason that Madhuri Madam wanted to use the quadrivalent. For circulation of influenza B is unpredictable. It has a larger disease burden, and also to broaden the protection against influenza B. And this is just an overview. We have the live and the inactivated. We have the first, second, third generation. The difference was the first was a whole virus, and the second was a split, and the third was a subunit. And of course, in the split, we had fragmented virus particles. In subunit, we just had the surface antigens. The advantage was that the immunogenicity being equal in subunit and split, but yes, the adverse reactions were lower down. And this safety was supplemented by a lot of groups for the safety concerns. So we are very, very sure that yes, it is very, very safe for a vaccine. Anybody in favor of cocooning?
Yes.
Upma, why do you like to do that cocooning? You think we'll stop the vaccines and we can go in only for cocooning?
Not only cocooning, ma'am, but it is recommended for the grandparents of the child care who takes care of the child. They should be better, because it is seen that the child the baby can get infection from the caretakers also. So the immediate parents.
Right. So Varsha Madam, do you like to go for cocooning or both cocooning and vaccine?
I am in favor of cocooning.
Cocooning? Okay. So ideally, you were in favor of cocooning, I think, because there is no influenza vaccine which was approved less than 6 months of age. But if we look, it is very easy. It could be effective, but it's so difficult. It may become very costly affair, and how many guardians are we going to monitor? So that is the reason we said, all of us decided that let's give an influenza vaccine. Cocooning is our choice to do or not to do. And so we move on to the other aspect, and that's a Tdap vaccine. Dr. Dhanalakshmi, we have something as TT, we have TD, we have Tdap. So which one and when?
Tdap is the preferred vaccine now. TT is the older one. I don't think it is manufactured anymore. TT was given early in the 2nd trimester and then 1 month apart. But now the prevalent vaccine is TD. TD's first dose is given as soon as possible, as soon as the person, the pregnant woman comes in contact with a healthcare worker, and the second dose is given 4 weeks later, and second dose is recommended at least 2 weeks before the estimated date of delivery to maximize maternal antibody response. Tdap is the vaccine now because protection from pertussis does not last as long as into the adulthood as we would like it to be.
Yeah.
And even if
So you
in
said,
childhood,
yeah, so you gave us a message that we need to use TD now. So the message goes that all from 10 to 16 years, we need to shift from TT to TD because TT would not be available now. And I think a lot of places they are not available since now also. So for, as she said, TD early in pregnancy, 4 weeks later, you give one and you give a booster. If the pregnancy occurs within 3 years of the last pregnancy and 2 of the doses of TT were already received, right? So now this question is for Dr. Udaya. 30 years old, Gravida 2 para 1, she had a seizure 4 years back. She comes back at 30 weeks this time and says, I want to have a Tdap vaccine. Now she received 2 doses in the first pregnancy and 2 doses of TT even in this pregnancy at the 4th and the 6th months respectively. So now she asks you, can I take this Tdap after 2 doses of TT?
Yes, she can very well take Tdap after 2 doses of TT.
Are you very sure for the safety?
Yes, ma'am.
Yes, ma'am.
Yes. Anybody else wants to differ? No, everybody is in favor of giving her a Tdap because so we've got a lot of safety data of the Tdap IPV given 1 month even after the TD IPV booster in young healthy adults, and there were no adverse effects. And there were 68,915 eligible VST enrollees received Tdap followed by tetanus containing vaccine, and they were followed for around 2.9 years, and they were found that yes, they do not have any adverse effects. And as we said, we are all shifting from TT to TD. Now, Dr. Upma, if she received Tdap in the previous pregnancy 3 years ago, does she need to take it again if she's coming to you at 26 weeks with 1 dose of TT taken?
Yes, ma'am. According to formula in 2014, every pregnant woman in every pregnancy, she has to take Tdap between 27 to 36 weeks of pregnancy, so as to maximize the response and pass.
Okay. So Dr. Upma gives us a wonderful message. And it is according to the guidelines, yes, 1 dose of Tdap in each pregnancy, irrespective of the patient's prior history of receiving a Tdap. Now, Dr. Swati, why do you want to give a Tdap in every pregnancy?
Because antibody response is maximum after 2 weeks of giving the first the Tdap, and it keeps on waning. So we have to repeat Tdap in each pregnancy to confer the best immunity to the baby and the mother.
Yeah. So that was wonderful because they found that there was a rapid waning of the antibody levels in 2 to 3 years, and you do not want to deprive your mother and the baby, and you want to give the maximum amount of antibodies to the baby. And so that was the reason that they said, yes, you give it in every pregnancy. So Dr. Dhanalakshmi, the preferred time of Tdap is 27 to 36 weeks. Why is it so?
This is because the maximum maternal antibodies response is between 4 to 6 weeks of the vaccination. And so if we vaccinate between 27 to 36 weeks, the mother will have the maximum antibodies and passive antibody transfer to newborns.
Yes. So wonderful panelists, because they want to give the maximum to the mother. And look at this, that what happens to the antibodies? They start to increase at 13 weeks, 5 to 10% of the maternal levels at 17 to 22, and 50% of the maternal levels at 28 to 32, and they exceed the maternal levels by 20 to 30% at full term. So there is an active transport that begins after 32 weeks, and majority of the IgG is acquired is in the last 4 weeks of pregnancy, and the placental transfer of IgG is generally linear, and the largest amount being transferred in the 3rd trimester. So that was the reason that we wanted to give her earlier. Yes. Now, Dr. Varsha, the preferred time, they say, yes, we will give it in 27 to 36 weeks. But are there any situations? There may be some reasons we will need to give her earlier. So what could these situations be?
Yeah, if she has any history of whooping cough in the previous pregnancy, one, or her baby who has suffered out of the infection of whooping coughs. That is the only situation where we can give it.
And sometimes we have a certain
serological test, if anybody has done, maybe negative, maybe that situation.
Right. So anybody else wants to add up anything for any other situation, special situation? Sometimes, you know, it may be just
there is outbreak of
yes, an outbreak may be there, or it may be outside the 27 to 36 weeks when she has a wound management. She needs to take it for that reason, and or it's an unknown, madam said, as unknown or incomplete tetanus vaccination. So that is the time. Those are the special situations where she may need to take this. So Dr. Madhavi, now she took a vaccination because of some reason of a special situation early in her pregnancy. So does she need to be vaccinated again during the 27 to 36 weeks of gestation?
No, because she was vaccinated once, her immune system would have boosted up and the antibodies would have been formed by then. So there is no need to take an additional dose. But if she had taken only TT prior, now at the 27 to 36 weeks, then we can give the three together, the Tdap and the pertussis and the tetanus. But otherwise, there's no need.
Right. So that means that we must take care if this pregnant woman comes anytime before the 27 weeks, we should give her a Tdap, and we do not need to repeat even by the guidelines that because those antibodies will not wear up very fast at that time. Now, Dr. Udaya, can this Tdap be offered as a part of a routine preconception care? Why can't we take it as a preconception vaccine? Dr. Udaya, are you there? Hello?
Am I audible, ma'am? Sorry.
Yes, yes, yes. Yes.
Yeah. The aim of Tdap is to prevent both the mother and the baby from all these three diseases. So when you give as a preconceptional vaccine, the immunity against pertussis does not last long as we wish to. So it's better not to give Tdap as a preconceptional vaccine, preferably only during pregnancy. Though it is not contraindicated, it is not recommended.
Fantastic. So that means we really do not need to waste the money of the patient. And of course, this protection is not going to last very long. We do not know when she's going to get pregnant, and those antibodies are going to wane down. And of course, we're not going to get that protective effect. So, Dr. Swati, now this young physician calls you at 8 o'clock and she says she's 6 weeks pregnant and has had a dog bite 10 minutes back. So she's advised anti-rabies vaccination, but she's so much worried, you know, it's an organogenesis period and she wants to avoid it. So how are you going to counsel her for this?
We are going to tell her that you can definitely take anti-rabies vaccination during pregnancy because the risk of acquiring rabies is much more than giving the vaccination, and rabies vaccine is considered to be safe during pregnancy if you are exposed to rabies. So post-exposure prophylaxis should be given.
So she can be given an anti-rabies vaccine. And now Dr. Varsha, she comes to you. She says, Swati has told me, yes, you cannot, but I couldn't sleep, you know, for the 2 nights. So I just want to ask you, please make it very, very clear to me, do I need to terminate this pregnancy because I cannot have an abnormal or a deformed baby?
No, actually, you should not. You should counsel her while giving anti-rabies vaccine. So, one. And second, if she comes with the queries, you have to talk to her, reassure her, and that's not the indication for termination of pregnancy.
Not a live vaccine.
Yes. So that is the message as she went, and so that's why that patient was counseled by Swati, Lakshmi, Dhanalakshmi, and Varsha, and she continued the pregnancy, and there was no outtake of it. So next we move on to the last, I think, aspect, and that is what can we all do to increase the vaccine uptake? Now, Upma, one question before I end to this: can she take the Tdap postpartum?
Yes, ma'am. Definitely, if she has not taken in pregnancy, she should take in postpartum period because 37% of the infants are infant pertussis happens through the mother only. So it is very much recommended. It did take 2 weeks time for mother to develop immunity, and therefore it is recommended in postpartum period.
Correct. We do not want to miss any window of opportunity. So if not taken, give her that vaccine. So 1 point for each one of you before we end. And that is Dr. Dhanalakshmi. What will you do to increase your vaccine uptake?
Counseling, madam. Counseling is the most important.
Counseling. Okay, Dr. Varsha.
First is counseling.
Yeah. And Dr. Udaya?
Counseling, madam.
Counseling. Dr. Madhavi?
Yes, madam. Counseling and convincing them.
Anything else you want to do? You want to put up posters, you want to put up something that, your patients start asking you, yes, sir, do I need, ma'am, I want to take this vaccine. Dr. Upma, any ideas for this, increasing the vaccine?
To educate the patient and also inform them the importance of vaccine, preventable diseases. Disease can be prevented.
Swati?
Ma'am, same thing.
Okay, so now let's go to the guidelines, what the guidelines say. So ACOG says you want to improve your vaccine uptake. So what do? You just incorporate your Tdap vaccination into a third trimester glucose screening that you're going, or if she's coming at 28 weeks for an anti-D immunization. RCOG says, yes, you can combine this vaccination from 20th week of pregnancy or just after your anomaly scan that you do. And Foxy says, yes, you can give this Tdap vaccination can be considered instead of a second dose to offer protection to your diphtheria and pertussis. So this practical schedule the first set of vaccines as soon as greater than 12 weeks as possible. TD, if not available, TT, but of course, we're not going to get it. And you give an influenza vaccine and the second vaccination, Tdap, if not available or feasible, then you go to TD. In case influenza vaccine has not been given, you give it with Tdap. Both of them can be given postpartum. So now to conclude, what are your challenges? What challenges do you face? One challenge from each one of you before we end. Dhanalakshmi, what is your challenge in vaccination?
Challenge is convincing the patient and making her come for vaccination, obviously.
Okay, Dr. Varsha.
And another is the price.
Yeah.
Cost? And Dr.
Yeah,
Varsha?
Cost is the factor, one factor, and the other is counseling to convince them for the taking the
So,
vaccine.
Dr. Uda?
They attribute all the negative things through the vaccine. So we need to, whatever happens, they blame it on the vaccine. So we need to have ready-made answers for that.
Yes. So all answers have to be ready before you're going to talk to the patient. Dr. Madhavi, what is your challenge that you face maximum?
Yes, madam. Convincing them to have this and trying to convince that it is for their and the fetus good that they have to take it is a very challenging.
Yes. Dr. Upma, any challenge that you face when vaccination?
Ma'am, the cost cost around 2,000 rupees each vaccine, Tdap as well as influenza shot. So it is very costly.
Okay. Swati?
Ma'am, cost mainly, cost factor.
Cost is the one. So any of you, I just wanted to put it forward. Have you faced mother refusing vaccination? She says, I don't want to take it. My mother didn't take. So this is sometime that we face. They have myths still. So we need to do a lot of counseling that you have all faced, and public misconceptions. We really need to clear out of the mind the vaccination, and of course fear of litigation. So the last question stands to you is, if she refuses the vaccination, do you put it in writing that she's not going to get a vaccination? Do you do it?
Definitely, madam. We have to take it in writing.
So we have to save ourselves legally. So I think the best is that you put into writing that yes, she is not ready for a vaccination. So vaccination is a strong move towards women's health. And thank you so much to all of you. I think we had to move a little fast because we were delayed, but yet we managed to finish it in a good span of time. And thank you to all my panelists, Dr. Upma, Dr. Varsha, Dr. Swati, Dr. Dhanalakshmi, Dr. Udaya, Dr. Madhavi, madam. You have given us fantastic inputs and crisp messages. And I think we learned a lot about vaccinating, and these were the newer insights into the women's health. So thank you so much, and over to Asha once again.
Thank you, madam.
There's a question in the question box.
Yeah, my panelists are there.
Answered that.
We've answered that?
Yeah, I've answered that.
Yeah, we've taken this question. So it goes.
Thank you. Thank you, Ritu ma'am. So it will be my most pleasant
Varsha madam
duty.
is saying, Varsha madam wants to say something. Yeah, Varsha madam.
Yeah, thank you, Ritu. It was really a wonderful panel, moderation of the panel, wonderful questions. And it was a rapid fire panel.
Yes, I thought we exceeded time, so we just take good messages. And Kiran madam, thank you for being with us till the end. Vanita madam, Ajay sir, thank you so much. And yeah, Asha, over to you.
Yeah, I have heard the best panel on the vaccination in my life. This is the best.
Thank you, sir. We're going to take this vaccination quite ahead. And we made ready reckoners for all our OBGYNs. We made FAQs, and that was in demand. We published another 10,000 this year and at the time of Foxy. And we are trying that we reach each and every obstetrician gynecologist to have this FAQs with them, so that at the time of troubleshooting, they are with there.
Thank you. Bye-bye.
Very nice. Thank you, ma'am. Should I give a very formal vote of thanks?
Yes. And I need to thank you also. So just a short formal thank you.
So,
I thank
you.
I want to
All
thank
good
Ritu
things come to an end. It's the best panel and very titillating lectures, but still, I thank Dr. Rishikesh Pai sir, Dr. Madhuri Patel, Dr. Asha Bakshi ma'am, Dr. Rajendra Singh Pardesi, and Dr. Sujata Dalvi ma'am for being here as our special guests. I thank our conveners, Dr. Komal Chauhan and Dr. Ritu Khanna ma'am, for putting this whole program together and involving us in it. I thank my co-coordinator, Alpana Kansal ma'am, who joined in at the last instance. Thank you, Ajay Mane sir, for opening our eyes to something we all know, but actually sort of push under the carpet and not pay much attention to. So thanks a lot for that lecture on documentation in tubal ligation. Thank you, Mala ma'am and Kiran Sinha ma'am, Vidhu, Dr. Vidhu, for chairing that session. Thank you, Dr. Komal, for your insights on postpartum contraception. Thank you to the chairperson, Sushma Gupta ma'am, Dr. Banita Sahar ma'am, and Dr. Shakuntala Kumar ma'am. I also thank Dr. Dhanalakshmi, Dr. Varsha, Dr. Udaya Banu, Dr. G.V. Madhavi, Dr. Upma Jaiswal, and Dr. Swati Gupta for being here as very expert panelists. I also thank Shield Healthcare for putting this whole program together. In the end, I would like to thank the whole audience who has joined in and has actually made the effort worthwhile. You put the whole program together and there's no audience, it doesn't work. Thanks a lot for being here. Thank you. Good evening and good night.
Thank you, Dr. Komal, for joining hands. Thank you, AMOGS and Family Welfare and MTP Committee. And my special thanks to our program coordinators, Dr. Asha Jain and Dr. Alpana. You were just in 24 hours, I think, we made up this things to be done. And that was fantastic. You took us flawlessly. That was a flawless input and execution. And my thanks to the Shield. Komal is there. Thank you, Komal, for joining hands. And you had really, passionate about it. And we can see your passion working. And all our best wishes once again to you and Mala Madam also. And of course, Team Shield has done a wonderful job. Sahiti was there all the time with us. And they gave us this platform. And we had a great knowledge sharing session. So thank you so much once again.